We will continue discussion about hemolytic anemia. We will discuss autoimmune hemolytic anemia type. Objectives at the end of this lecture. The student should be able to define the autoimmune hemolytic anemia, identify major causes of warm and cold autoimmune hemolytic anemia, understand the pathophysiology of autoimmune hemolytic anemia. He can describe a clinical presentation of autoimmune hemolytic anemia, understand the difference between warm and cold antibody-mediated disease, and he should have idea about the treatment options for autoimmune hemolytic anemia. What is autoimmune hemolytic anemia? Autoimmune hemolytic anemia is destruction of the red blood cells characterized by shortened red blood cell survival, presence of autoantibodies directed against autologous red blood cells, and a positive direct antiglobulin test or COMS test. Most patients with autoimmune hemolytic anemia exhibit warm reactive antibodies of IgG isotype on their red cells. The remainder of patients exhibit cold reactive autoantibodies. Cold reactive autoantibodies are recognized as cold agglutinins, which are IgM type, and cold hemolysins, which are of IgG isotype. The direct antiglobulin test or COMS test might detect IgG, fragments of complement C3, or both on the red blood cells of patients with warm antibody autoimmune hemolytic anemia. In cold antibody autoimmune hemolytic anemia, only complement is detected. 50% of patients with autoimmune hemolytic anemia have no underlying associated disease, which is called primary autoimmune hemolytic anemia or idiopathic. Secondary cases are associated with underlying autoimmune diseases, malignancy, infectious diseases, or with ingestion of certain drugs. Okay, we will start with warm reacting antibodies autoimmune hemolytic anemia due to the development of an IgG antibody. IgG antibody against red blood cells. Antibody active at temperature of 37 degrees Celsius. Two types. Primary, we don't know the cause. Secondary, to an underlying disease, such as lymphoproliferative disorders, Secondary causes of autoimmune hemolytic anemia: worm-reacting antibodies, such as lymphoproliferative disorders, chronic lymphocytic leukemia, lymphoma, Waldenstrom disease, or multiple myeloma. Autoimmune diseases such as systemic lupus or rheumatoid arthritis. Infections, immunodeficiency disorders, especially HIV, and certain tumors. The incidence of warm autoimmune hemolytic anemia is 1 to 3 cases per 100,000 population per year. There is female predominance. Primary more common in women during the 4th and 5th decade of life. Mechanism of destruction of worm-reacting antibodies autoimmune hemolytic anemia. It is extravascular hemolysis. That means in the macrophage, in the liver or spleen. Antibodies bind to the surface of red blood cells membrane. Fc portion of the antibody binds to Fc receptor on macrophage. In the macrophage, red blood cells will be destroyed and they will become spherocytes, small in size because some part of the membrane is removed by the macrophage. The spherocytes became trapped in spleen and are destroyed in the spleen, leading to hemolysis. These are red blood cells with many antigens in the cell membrane, and these red blood cells, they are coating with autoantibodies. The autoantibodies has variable region which fixed to the red blood cells, and Fc portion which will be fixed to the macrophage where the Fc receptor is present. This immunoglobulin G will be fixed on the red blood cells. Red blood cells coated with the immunoglobulins will be captured by the macrophage, become spherocytes, and will be destroyed in the spleen, or the spleen direct will destroy this coated red blood cells. This in the cold reactive autoimmune hemolytic anemia. Warm reactive autoimmune hemolytic anemia. In the cold reactive portion of complement activate the immunoglobulin M, and they will be fixed on the red blood cells, and these red blood cells coated with immunoglobulin M will be destroyed in the liver, in the Kupffer cells. Kupffer cells are equivalent to macrophage in the spleen. After rupture of the membrane, hemoglobin will go out. Cold agglutinin disease. or autoimmune hemolytic anemia with cold agglutinin antibodies. They are due to development of an IgM autoantibody. Antibody active at cold temperature 4 °C. They are primary or secondary. Secondary to an underlying disease such as lymphoproliferative disorders, infections, immunodeficiency disorders, autoimmune disease, and tumors, the same as in autoimmune hemolytic anemia with warm antibodies. The prevalence of cold agglutinin disease is less common, 14 cases per million population per year. Effectors mechanism for immune cell destruction. Two main effector mechanisms exist in vivo, or cell-mediated, predominantly extravascular immune destruction in the spleen or liver by macrophage, or complement-mediated intravascular hemolysis by IgM and complement. This IgM is called pentamer, has 5 branches, hemolyzes through membrane attack complex, warm IgG autoimmune hemolytic anemia being removed by Kupffer cells in the liver, and these are Donath-Landsteiner IgG hemolyzes through membrane attack of complex of complement. Mechanism of destruction in cold reacting antibodies autoimmune hemolytic anemia. Intravascular hemolysis and extravascular hemolysis. Intravascular IgM antibodies fixed on red blood cells activate the complement system, resulting in cytolysis in the circulation. Extravascular hemolysis C3b occurs in the liver via action of Kupffer cells. Here an overview of classification of autoimmune hemolytic anemia should be known and in mind all the time. Autoantibody warm reacting autoimmune hemolytic anemia type, we said that immunoglobulin G is the responsible. Autoantibody maximal active at body temperature of 37 °C. They are primary or idiopathic and secondary to lymphoproliferative disorders, rheumatic disorders such as systemic lupus, rheumatoid arthritis, certain neoplasms such as ovarian tumors, associated with chronic inflammatory diseases such as ulcerative colitis, associated with ingestion of certain drugs such as methyl dopa. Cold autoantibody autoimmune hemolytic anemia type. Autoantibody optimally active at temperatures less than 37 °C, usually at 4 °C. They are two types mediated by cold agglutinins IgM mediated by cold hemolysins IgG immunoglobulins. Those mediated by cold agglutinins are idiopathic or called chronic cold agglutinin disease. Chronic cold agglutinin disease and secondary cold agglutinin hemolytic anemia, secondary to mycoplasma pneumonia, infectious mononucleosis, or they are associated with malignant B-cell lymphoproliferative disorders such as chronic lymphocytic leukemia or lymphoma. Mediated by cold hemolysins immunoglobulin. Idiopathic, which name paroxysmal cold hemoglobinuria. Remember that we spoke about paroxysmal nocturnal hemoglobinuria, the defect in the red cell membrane, and hemolysis during sleep. And this is paroxysmal cold hemoglobinuria. Secondary to Donathan-Landsteiner hemolytic anemia, usually associated with an acute viral syndrome in children, congenital or tertiary syphilis in adults. There is also mixed cold and warm antibodies and drug-induced autoimmune hemolytic anemia, hapten or drug adsorption to the red blood cells, immune complexes, and true autoantibody mechanism such as in methyl dopa. The characteristics of autoantibodies. The autoantibodies might be produced by the patient's own immune system and directed against his or her own red blood cell antigens. These autoantibodies. Alloantibodies are produced by the patient and directed against foreign red blood cells antigens as in blood transfusion. Also, alloantibodies directed against the patient's red blood cells antigens from the mother in hemolytic disease of the newborn. Clinical features of autoimmune hemolytic anemia. There is a general clinical feature such as weakness, drowsiness, headache, inability to do usual work, exertional dyspnea, and warm type autoimmune hemolytic anemia. The presentation is variable and depends on speed with which anemia develops, the capacity of the bone marrow to compensate. We said after destruction there is bone marrow compensation, and if the destruction is over, the compensatory mechanism anemia will appear. The effects of any associated disease. The onset is insidious with gradual awareness of symptoms of anemia or the observation of pallor or icterus by friends or relatives. Occasionally, the onset is acute with rapidly developing anemia, and in older patients, the risk of heart attack. Rarely severe cases can occur with fulminant hemolysis resulting in life-threatening anemia. Pallor, mild jaundice or tinge of jaundice, not deep jaundice. T-color urine, mild splenomegaly, low-grade fever, and low back pain. Laboratory findings in warm antibody autoimmune hemolytic anemia. The peripheral blood film is characterized by reticulocytosis or polychromasia. Red blood cells are small spherocytes. Circulating nucleated red blood cells or normoblasts. Increased unconjugated serum bilirubin. Increased urinary urobilinogen. Increased lactate dehydrogenase. The direct antiglobulin test is positive of red cells coated with IgG alone or IgG and complement. How can we treat a patient with warm type autoimmune hemolytic anemia? Corticosteroids are the first line treatment of warm autoimmune hemolytic anemia. The initial dose should be with prednisolone 1 to 2 mg per kg daily for 10-14 days, then tapering gradually. Folic acid supplement. Immunosuppressive drugs such as azathioprine, cyclophosphamide, cyclosporine, mycophenolate, or Cellcept. Intravenous immunoglobulin, splenectomy, rare monoclonal antibodies therapy, anti-CD20 rituximab are used. Blood transfusion in patients with autoimmune hemolytic anemia has many problems. So blood transfusion should be given only if the clinical situation demands it, especially when hemoglobin continues to be decreased to full permanently. If heart failure develops, there is impossibility of achieving a satisfactory cross-matching in the presence of a positive direct antiglobulin test. COMS test is positive in chronic in autoimmune hemolytic anemia, and it is the main method of testing compatibility in blood transfusion, and it is already positive in this patient. But the least incompatible grouped blood should be used under monitoring of blood transfusion, which should be slowly. The prognosis in warm autoimmune hemolytic anemia depends on a number of variables: age, associated diseases, severity of hemolysis. Mortality in adults vary from 10 at 5 years to 40% at 7 years. The clinical feature of cold hemagglutinin syndromes vary with the pathogenesis of the disorder. Cold type autoimmune hemolytic anemia is uncommon disorder, accounting for only 15% of autoimmune hemolytic anemias. Idiopathic cold agglutinin or hemagglutinin disease. The clinical feature is mainly seen in older people and runs a chronic course. Purplish skin discoloration, maximal over the extremities, called acrocyanosis. Cyanosis in the peripheries, or acrocyanosis is a stasis in the peripheral circulation secondary to red blood cells agglutination, forming a clot which stops the circulation in the small vessels in the peripheral circulation. In idiopathic cold hemagglutinin disease, anemia is usually present, as well mild jaundice. Spontaneous agglutination of red cells is observed both macroscopically on blood film if made at room temperature. You can see in the slide by your eyes. The direct antiglobulin test or COMS test show C3D component of complement on the red blood cells. IgM cold agglutinins are not detected because they elute from the cell surface in vitro after washing of the red blood cells. This agglutination of red blood cells in the peripheral blood forming small clots which cause acrocyanosis. The red blood cells should be separated, not clotted like this. This acrocyanosis, nose, ear, and toes, fingers. The treatment of idiopathic cold hemagglutinin disease. Management of cold hemagglutinin syndromes is difficult because there is no response to any therapy. All patients should avoid exposure to cold. This is the main step of treatment. Avoid exposure to cold. They made electrically heated gloves and socks are available for use in winter in cold weather. The patient should be nursed where in a warm environment, preferably at 37 grades Celsius. But also we should give for patients with idiopathic cold hemagglutinin disease folic acid supplement, alkylating agent such as chlorambucil, which is used in chronic lymphocytic leukemia and lymphomas. Corticosteroids are rarely of use, as well splenectomy is rarely of any use. But the anti-CD20 monoclonal antibodies such as rituximab could be given to a patient with idiopathic cold hemagglutinin disease. Blood transfusion is difficult in patients with autoimmune hemolytic anemia. So blood transfusions should be given in spite of the difficulty in cross-matching in the presence of cold hemagglutinins if the patient is in heart failure only. If there is severe symptoms of anemia, such as dyspnea, orthopnea, tachypnea, blood should be given through an inline blood warmer. Hot blood, not cold blood. And plasma exchange or plasmapheresis, removal of the autoantibody from the circulation. The titer of cold agglutinin might be lowered temporarily by plasma exchange. Paroxysmal cold hemoglobinuria. This is rare syndrome, usually occurs in children following acute viral infections. The original cases were described by Donald Landsteiner in syphilis. Presentation is with sudden intravascular hemolysis resulting in pallor, dark urine, abdominal pain, sometimes collapse, and hypotension. The cold antibody is a biphasic polyclonal immunoglobulin G called Donat-Landsteiner antibody that reacts with red cells below 20 degrees Celsius in the peripheral circulation. That means when the blood in fingers or in nose, the antibodies will be fixed on red blood cells, causing lysis by complement activation as the red blood cells are warmed to 37 degrees in the central vessels. Antibodies will be fixed on red blood cells in the peripheral circulation and destroyed in the central circulation when the blood is coming to the heart, where the temperature is 37. This antibody is called biphasic or Donat-Landsteiner antibody, fixed on peripheral blood in cold and destruction when this blood is warmed in the central circulation. Treatment depends on keeping the patient warm only. Hemolysis is usually self-limiting. Transfusion of AB0 and rhesus compatible should be given through a blood warmer only and only when patient is in severe need, in major need. Otherwise, no blood transfusion. Laboratory general features of autoimmune hemolytic anemia. Patients present with anemia varies from life-threatening to very, very mild anemia. Patients may have leukopenia and neutropenia, or leukocytosis and neutrophilia. Evaluation of blood film can reveal can reveal several features related to all types of autoimmune hemolytic anemia. Polychromasia indicates reticulocytosis, spherocytes, small red blood cells. These spherocytes without central halo, without the central halo, this is central halo, but this spherocyte has no central halo. That means full of hemoglobin. That part of the red blood cells membrane was removed by macrophage due to coating with autoantibodies. And as a reactive or compensatory mechanism, there is hyperproduction, and due to hyperproduction, the reticulocytes will be high in the peripheral blood, called polychromasia. This polychromasia, the red blood cells, instead to be pink in color, they are green. Platelets, they are large in size as a compensatory mechanism. Thrombocytosis and neutrophils. This nucleated red blood cells. This Howell-Jolly body, small dot. Howell-Jolly body, small dot. Microspherocytosis, small red blood cells without central halo. This is central halo, this normal red blood cells. These are nucleated red blood cells. Nucleated red blood cells are present in the bone marrow, not in the peripheral blood. In the late normoblast, this nucleus will be removed, transformed to reticulocytes, which will be eliminated from the bone marrow to the circulation. So red blood cells fragment might be present. Nucleated red blood cells might be present in the peripheral blood. Erythrophagocytosis by monocytes. That means monocyte will eat red blood cells. Patients with cold antibody autoimmune hemolytic anemia may exhibit red blood cells autoagglutination in the blood film and in child anticoagulated blood. This you can see it by your eye. Marrow examination reveals erythroid hyperplasia as in any type of hemolysis. Total bilirubin is increased. Indirect bilirubin or unconjugated bilirubin is increased. Urinary urobilinogen is increased. Serum haptoglobulin levels are low, especially in intravascular hemolysis in cold reacting and autoimmune hemolytic anemias. Lactate dehydrogenase levels are elevated. Hemoglobinuria is rare in patients with warm antibody autoimmune hemolytic anemia and is common in patients with cold agglutinin disease, paroxysmal cold hemoglobinuria, and drug-induced hemolytic anemia. This is red blood cells, red blood cells antigens, this autoantibodies fixed or coated on the red blood cells. How we can diagnose the patient with autoimmune hemolytic anemia? By direct COMS test or direct antiglobulin test. blood sample from a patient with immune-mediated hemolytic anemia. Antibodies are shown to attach to antigens on red blood cells. This autoantibodies. And the red blood cells are not agglutinated. Before these red blood cells will be washed and are incubated with anti-human antibodies. These antibodies, there is anti-human antibodies or COMS reagent. These red blood cells will be incubated with anti-human antibodies or COMS reagent. These anti-human antibodies will be fixed on these autoantibodies and forming a clot of red blood cells. Red blood cells agglutinate. Anti-human antibodies form links between red blood cells by binding to the human antibodies on the red blood cells. This positive COMS test or direct antiglobulin test. This if the autoantibodies are fixed on red blood cells, but sometimes the autoantibodies are not fixed on the red blood cells. We should use indirect antiglobulin test. These antibodies are in the serum, should be fixed before on the red blood cells. We should add after that COMS reagent. This is direct, this is indirect COMS test. And the next step will be agglutination of coated red blood cells and anti-human antibodies or COMS reagent. This direct antiglobulin test, this indirect antiglobulin test. Differential diagnosis of autoimmune hemolytic anemia. Several non-autoimmune diseases may result in spherocytic anemia. Hereditary spherocytosis, Clostridium velkis sepsis, hemolytic anemia preceding Wilson disease, this congenital disease. You will study it in the gastroenterology. Drug-immune hemolytic anemia, recently blood transfusion, recent allogenic stem cell or organ transplantation. As a summary, we can summarize the difference between warm-reacting autoimmune hemolytic anemia, cold-reacting autoimmune hemolytic anemia. The warm-reacting antibodies react at 37 degrees Celsius, while the warm antibodies reacting autoimmune hemolytic anemia react at 37 degrees Celsius, while in cold reacting react at room temperature, especially at 4 degrees Celsius. The onset is insidious to acute in warm and chronic in cold reacting. Warm reacting, there is severe anemia, while in cold reacting antibodies, less severe anemia. In both, there is fever and jaundice. Destruction in warm reacting antibodies is extravascular in the spleen and liver, while in cold reacting intravascular in the circulation. There is no autoagglutination in warm reacting antibodies, while in cold there is autoagglutination causing acrocyanosis. In warm reacting there is urobilinogen in the urine, while in cold reacting there is hemoglobin urea. Acrocyanosis is present in cold reacting autoimmune hemolytic anemia, whereas there is no acrocyanosis in warm reacting. Organomegaly spleen may be present in warm reacting, no organomegaly in cold reacting autoimmune hemolytic anemia. Response to steroids is good in warm reacting, while there is no response to steroid in cold reacting. Any questions at any time?